Yes, Alan, we're ready for you. So we can look at the screen.
That was a really excellent description of the field, and some of what I'm going to say reflects a lot of what Melinda just talked about in terms of the difference between commercial and safety net populations, with the three factors being of relatively different sizes, though I have a slightly different way to describe it. My job is, I'm the co-director, along with my wife, Dr. Ann Lindsay, of a program at Stanford called Stanford Coordinated Care, which is designed for the employees and dependents of Stanford University and also the two hospitals, Packard and Stanford Healthcare, which is for adults. And we were brought to Stanford approximately 3.5 years ago by Arnie Milstein with the mandate to create what he called AICU 2.0, Ambulatory Intensive Care Unit 2.0, and got to build a program exactly from scratch, which is a rare opportunity in this or any other life. What we did in the beginning was go out and talk to about 35 people who fit the description of multiple chronic conditions, not doing well, and employee or dependent at Stanford. And based on what we learned in those conversations, and we utilized a methodology called human-centered design, partnering with a firm called IDEO in Humboldt County, in the Bay Area, and designed our program based on what the patient said. So earlier comments by Allison about that, I think, are really pertinent, because you're going to get it wrong if you sit and think from within the viewpoint of the delivery system what's needed without getting that information. Let me forward to the next slide now, and I'll describe more about what our program is and where it came from. So please forward the slide. We have a disclaimer on slide 2, which is that some of this data came out of the CMMI grant that was paid for, but just ended June 30th, called the Intensive Outpatient Care Program. I believe Lisa Mangiani is in the room, and she was director of that program. And then go to slide 3, is the whole concept of doing this work within commercial populations. It's somewhat different than it is in the safety net, and I'll get into that in more detail a bit down the road. But the history of this, there were originally 2 pilots that Arnie helped bring about, one of them at Boeing up in Seattle area and the other in Atlantic City. The Boeing population was, engineers and people that build airplanes. The Atlantic City population was a very different population, though employed, in that they were hotel worker, restaurant worker, and casino workers in Atlantic City who were part of a national health trust called Unite Here Health, which is still up and running, and is a national organization replicating the work in Atlantic City in Las Vegas at the moment as well. And what they were able to achieve through a payment model of capitation plus a fee-for-service for the doctor billable events, they were able to see roughly an 18 to 20% reduction in per capita spending that has been kind of the target for all the subsequent efforts. The actual data there did look at match controls through propensity matching, and what it showed was that the directional change, and you can go to slide 3 in this regard, or slide 4, the next slide. It showed directionality, but not clinically. We were not significantly achieving results in terms of p-values, and it had to do with insufficient denominator size to power the study. So that study then, the same intervention came to where I formerly was the chief medical officer of a countywide independent practice association in Humboldt County, in Northern California, and partnering with the Public Employee Retirement System and Pacific Business Group on Health, and Anthem serving as the ASO, or third-party administrator to the program. We took an initial 400 people, recruited them into a program that was based on the model I'm going to show you in a couple of minutes, and achieved essentially a similar amount of savings within a single year on those people. This was not run through an integrated delivery system, as was the case with Boeing, or through a single clinic, as was the case with Atlantic City, but rather spread out across 25 primary care practices in a rural county. The good news was that we had done a lot of work about primary care redesign in those practices in the prior decades, so we were not just walking into the Wild West. And savings were, the net savings were approximately 16% in the first year. The propensity matched look at this has never been done, and which I think is unfortunate. But despite that, the program has grown to be the core of an ACO in Humboldt County now, and I believe there's something like 5,000 people in the pipeline to enter the program over the next few years. Based on that work, Arnie recruited my wife and I to come start a similar program at Stanford. And what we did at Stanford was these interviews, build the program. It's paid for as a capitation for an augmented level of service within primary care that includes social work, behavioral health, and physical therapy. It also includes patient education. We have access to one of the best patient health libraries in the world, and they attend our rounds every week and supply information to patients that isn't readily available in a trustable form, even through the internet. And I'll show some of the early results of that when I describe the program. So let me move to slide 5 now, which is a different way of looking at the Venn diagram that Melinda just showed us, and I think of it in a slightly different way. There are patients with high needs, and clearly, if you throw in functional needs on top of medical needs, the cost goes up precipitously. Most of that care delivered by low-income people with relative lack of training, and it was interesting. Jeremy's story about being stranded on a Sunday morning because his caregiver didn't come back really resonated with our experience in this work as well. In that, we need a whole new professional track for people that supply such work. And right now, it's generally languishing down in the lowest pay rung, and the caregivers themselves often have a lot of chronic conditions, and their health suffers due to the role that they're playing. In other circumstances, it's done by family, but all the same risks are associated with it, family as otherwise. And clearly, if people end up in long-term institutionalization as a result of lack of caregiving, then you're talking in the Bay Area of California, Northern California, you're talking about $95,000 a year at that point. So there are patients with needs. There are also patients with high waste. And I define waste by people who are going to the emergency room over and over again. A medical student working with us at the moment, Grace Hunter at Stanford, had just got off of a rotation where she was working in on the inpatient ward and outpatient clinic that serves patients with congestive heart failure. And they've been doing a lot of very excellent work around readmissions, trying to reduce readmissions. And what they've discovered is there's this core of patients that getting admitted to the hospital is the best part of their life. Food is reliable, the bed is warm, nice, interested people come and sit and talk about your problems. And these are 3 things lacking in these patients' lives outside of the institution. So they get admitted over and over again. And those people are an example of waste in a healthcare system. It's not waste from their point of view. They're making a really intelligent choice given their options. But from the system's point of view, can't we supply those needs in a better way than at the cost of an inpatient bed at Stanford, which is quite high, actually. And then there's this subset of people that show both high need and have waste. And if you focus on them, you're much more likely to produce an ROI in a short period of time. if you meet those needs in a less expensive manner. And that work is glorious work and leads to publications, but it ignores the high needs people that where savings are not probably in the mix. What we're trying to do is spend less than it would be if we were not there, but that's actually hard to show. I've seen some creative math around that that would not pass the muster of the academics at Stanford looking at it. Is this really a change or not? So I think what we need to do is really think about time frame. If you're working with a patient who has out-of-control diabetes, hypertension, hyperlipidemia, they could dwindle along in that state for a decade before things really break loose and suddenly amputations and renal failure and blindness happen. And then suddenly the costs go up. But in the 10 years prior to that, usual care is also failing a number of our patients, as we know. So let me go to the next slide, which is the one that talks about the care model. And we talked about, Melinda talked about the concept of amenability to change, and I think that's a very interesting issue. I always use this joke from Hagar the Horrible to kind of talk about that. And a lot of the perception of lack of amenability to change, I think, arises as a result of the delivery system's failure to offer appealing options. And talking at people, wagging the finger of warning, or that whenever I see that in a medical student or a resident, I always say, put your finger down. It's not the right thing to do is to wag it at somebody and tell them what to do. But trying to understand why people are stuck is really at the root of a lot of this work, and I think something we've made a lot of progress in. So thanks to our colleagues at Care Oregon, and I believe Rebecca Ramsey's in the room, and she authored this, though it was adapted by us in Humboldt to combine medical status and health trajectory. We use a concept of what, in terms of defining what the patient is facing, we use this domains tool, which sorts people into 4 categories of challenge. One of which, medical neighborhood, the upper left, could be considered access. Another aspect of that is just basic trust. And what we find in a lot of our patients, and it would be, the Hagar's joke, I think, encapsulates it well, is that people have lost the trust in the healthcare system over many years because every time they go in, they're told they're a failure and they're not doing well and they need to change their lives. And I don't know about the rest of you in the room, but I myself, faced with type 1 diabetes, tend not to enjoy medical visits that go that way. And then if you look at the upper right, social support, which in seniors is the predominant cause of hospitalization more than any other single condition, the person needing a caregiver and the caregiver burns out, and then suddenly it's thrust back on a family who may live remotely, and then the patient is brought to the emergency room on a Friday night, it's very unlikely that that person will ever end up back in the home. And then we're talking about $95,000 a year. We did work looking at how do you keep frail seniors in their homes as opposed to have them be institutionalized with IDEO. We were trying to design a new approach to keeping people in their homes. And what we heard from people in the long-term insurance industry, long-term care insurance industry, is that they had basically stopped writing policies on people that didn't have spouses, that it was such an important determinant in their book of business, that lack of spouse was a reason not to insure somebody because it would obviously break the bank. Going to the bottom right are the usual candidates of people who are not self-managing well and often have depression and other behavioral issues going on. And then the bottom left, and not to forget them, and Jeremy's discussion clearly encapsulates a lot of the challenge being faced there. Some people, through diving into the wrong quarry or other events in their life, are dealt a hand that would challenge the most functional person on earth, and it sounds like Jeremy may well be that person, to maintain a healthy existence and the work-life balance he seeks. So we sort people into those 4 categories, and then go on to the next slide, please. And then what we do is using a tool called the Patient Activation Measure developed by Judith Hibbard at Oregon Health Sciences, we figure out their quote-unquote amenability to change. And it has to do, it's 13 questions, likely many of the people in the room are familiar with this, but it sorts people into 4 levels of functionality around health. And it has to do with the concept of activation or confidence. And level 1 is euphemistically described as starting to take a role, but I usually call it checking out. They've just sort of signed off on healthcare and let it come what may, and then they deal with it and suffer, and they generally live a lot shorter life than other people. Level 2 is people who are starting to move up the scale. Level 3 are people who are doing it, but things can get in the way. And level 4 are people that are going to maintain it no matter what happens. And then we put those 2 things together, and then we have a pretty good sense of what the intervention with an individual patient should be. What we find in those meetings is that there's very high degree of depression in this population, and that was referred to in the original comments of the day by Peter, that having depression doubles the cost of many diseases. And depression as a comorbidity for other chronic illnesses is visible in slide 10. If you want to just see a picture, is it a chicken or an egg? But chronic pain is the winner for many of us practicing in primary care. I'm a family doc, so I've been seeing this my whole career. And the rate of depression in people with chronic pain is in the, somewhere around half, which is quite high. And for all the other chronic diseases, it's also very high. So next slide. What we discovered in this work is that there was a hidden driver of a lot of people who have low activation, which is the concept of adverse childhood events, or ACEs. Rich literature on this. You're going to hear more about it later in the day, so I won't spend a huge amount of time on it. But basically, people who answer positively on slide 11 to 4 or more of the bullets listed on that slide are likely to have a life expectancy a lot shorter. If you have 6 of them, your life expectancy is 20 years shorter. And on the following slide, slide 12, the obvious results we know about this are increased smoking rates, COPD as a result of those smoking rates, depression much more likely, and the real chiller to me is the suicide rate of people who had adverse childhood experiences. We learned about this work because we did work with the VA and saw what they were doing with PTSD, and then realized, well, what we're looking at is PTSD, but it started at age 3 or earlier, and then we utilized a lot of the techniques that the VA has developed to deal with returning vets with PTSD. So our model is basically, we have to win back trust in people who've by and large lost it. And we do that by focusing on what they care about, not what we care about. And if you go in and say, you're costing the system too much, that isn't very appealing to most patients, and I'm sure nobody in the room is shocked by that. So what we ask them is, what does bother you? What do you want? And then we also ask them in our 2-hour intake, what would it look like in a year if we were successful helping you reach your goals? And then we do that, and often it really requires that we bite our tongue about our goals. I took care of a man who came in with a A1C of 16, which is, for the non-medical people in the audience, one of the highest numbers on the planet. I'm sure others have higher numbers, but it's the highest one I've ever seen. His blood pressure was way out of control, his cholesterol was way out of control, and he hadn't taken a medicine in 2 years. And what bothered him was something going on with his heart. He was having arrhythmia. We focused on what bothered him and not what was so glaringly wrong. But we were able to tie it to what was so glaringly wrong about his lack of self-care. But we addressed the arrhythmia, which is what bothered him. And by about month 3 of that interaction, he came back and he said, don't you think if I took better care of my diabetes, my heart rhythm would do better? And we said, oh, great idea. And Now his A1C is in the 5s. Every other item is under perfect control, and the arrhythmia vanished without the ablation he came in seeking. So reduced cost. Just another really quick case study, which is slide 14. A man with lupus and renal failure on dialysis who had been septic monthly for about 6 straight months to great and incurring great costs came in. And what I realized was that he was seeing multiple specialists for his different issues. He had an eye problem related to the lupus, and he had renal failure. And he was on prednisone from one doc and Cellcept, which is an immune modulator, by another doc, and they were both at maximum doses to treat the individual problems of eye and kidney. And what we were able to do was get all the specialists together on the same page, no magic in this, and get them each to reduce the dose of the drugs by half. We learned in that meeting that they were getting very frustrated with this man who is actually a medical assistant at Stanford, gets up and does dialysis 3 nights a week, showers, and then goes to work the next morning. So it's kind of a heroic man in many ways that he's working full-time and he's also blind in one eye. He had been missing the occasional appointment for the liver transplant because the kidney transplant because he never had it. Nothing ever happened of value in those things because they kept putting him off. We don't have a kidney yet for you. Sorry. And told him that if you stop going to those meetings, those clinic visits, you're going to end up off the kidney list. So he became very, very adherent at that point. And what we were able to do was eliminate sepsis. And what had been $600,000 in the previous 6 months fell to $7,800. Big success. If you had a lot of these, you have a great ROI. But this is an example where there was a lot of waste going on, and the waste was 2 specialists not talking to each other. So, our results, and I won't take you through each of these, have just been very positive clinically. If you look at the patient activation measure, which I make a case for being the outcome measure of this work, and this was the patient activation work done at Humboldt. It showed that there was a spread of people level 1 through 4, and what happened after a year was that all the levels 1, 2, and 3 fell, and level 4 went up a lot in the course of a year through this method of focusing on what patients care about and using behavior change techniques. We did in the intensive outpatient care program, which I served as one of the clinical advisors under Lisa Mangianti, almost exactly the same PAM graph occurred, and where all the levels went down in the post-study compared to the pre, except level 4, which went up. And then if you look at our results at Stanford, you see the same thing, though you see a difference here as well in that levels 3 and level 4 dominate at Stanford, and that's what you would expect from this environment. What's interesting is we still have 5% that cost 50% of the money, but they're not showing up at the ER all the time. It isn't that there's that kind of waste in the Stanford system. What there is people not taking good care of themselves. And we have been able to change that in a measurable way. The slide 19 shows Judy Hibbard's research on what happens when people move PAM levels. And I have 2 that I've circled on this. So people that move level 3 to level 4 compared to people that stay at level 3 both times, cost $600 a year less. And in people that move from level 1 or 2 to 3 or 4 costs a lot. We're now at $1,000 less than people who stay level 1 or 2 on a per capita cost. And this is a study of two years in the Fairview system in Minneapolis with an N of 33,000. So it's a really well-powered study. And then we looked at that, if you go to the next slide, in our own data at Stanford, and we have moved a significant number of people in the categories that are associated with significant savings. We don't yet have good financial data, and that's a long story. My final slide will just briefly talk about that story, which is Regression to the mean is, not in any given year, 2/3 of the people who are high cost one year won't be the next, is obviously the elephant in the room. And many disease management programs run by health plans over the years have taken credit for the regression to the mean. If you can get away with that, I guess it's a great business model, but it certainly doesn't work in the environment I'm in these days. And what you find out is that the people with uncontrolled chronic conditions are likely to stay in that group, though the costs may not really hit for up to a decade, depending on what's going on. And that people with uncommon conditions that are expensive will likely stay in that group as well. But in both of those, you can make a big difference. What you don't want to do is spend a lot of energy on the people who are going to get better without you. And then the question of what's a matched control group arises. And I think the best methodology of that is to you can enroll people in phases and let the people who enroll later be the controls to the people who enroll earlier. We also are looking at people who disenrolled, but we still have their claims data going forward, and there have been something like 50 people that has happened to in our program. They either graduated or left Stanford, but we can still get their data, or they didn't like us, which is very rare, actually. I think it's only been 4 or 5 people. And what we've seen there is that once they leave us, costs went back up, which is interesting, but I don't have really solid data on it. So let me stop here and move on.
Great. Thank you very much. That's a lot to